Hello and welcome everyone to today's webinar. Thank you for taking time out and being here today. My name is Dr. Gurudat Nayak. I'm the principal of Mansoor Dental College, Bhopal, and I head the Department of Conservative Dentistry and Endodontics. Today we are hosting a webinar on management in failures in composite restoration. I'm pleased to introduce our presenter for today's session, Dr. Pallavi Patil. Dr. Pallavi Patil did her graduation from D.Y. Patil Dental College, Mumbai in 1996. She has done MBA in Healthcare Management from Wellingकर Institute of Management, Mumbai. She was in private practice in Pune for 12 years. Presently, she is with 3M Oral Care Solution Division as Scientific Affair and Education Manager, India. She is trained in Advanced Material Science from 3M Germany. She previously held position as Scientific Affairs Manager Marketing at Colgate, India. She has conducted several workshops on both restorative and prosthodontic topics and has been actively lecturing on clinical and non-clinical dentistry related topics in conferences, local organizations, colleges, study clubs, career forum, etc. She deals with training and development courses on 3M range of products and their clinical allocations. We are pleased to have her for this webinar. I would like to request all the participants, if they have any question during the presentation, please type them in the question box in your control panel. They can also raise their hands and we will be pleased to let the participant directly talk to the speakers for any doubt. The question and answer session will be taken up at the end of the presentation. Without taking any more time, I would like to request Dr. Pallavi Patil to start the session.
Thank you, Dr. Nayak. It's indeed a great pleasure to be here. Okay, you can hear me, right? Yeah, so good afternoon, everyone. Firstly, Dr. Nayak, thank you very much for giving this opportunity. It's always a pleasure addressing college students. They are the best days. And I think what we learn there is, priceless. Having said that, I also know that over the period of time in our clinical practice, we kind of move away from the theory and we get into a set mindset of how to do things. It's always good to go back and look at the basics, or also more importantly, how what we are studying is relevant as far as the clinical implication is concerned. So thank you once again for giving this opportunity to address the students, and thank you for the kind introduction. So today, of course, as Sir said, the topic is failures in composite restorations. This is a very interesting topic, slightly theoretical, nevertheless a very, very important topic as far as we are concerned with day-to-day clinical practice. Having said that, I have a request for all the participants. It would be great if you could put your questions or comments in the chat box. It really gives a great pleasure to see. Okay, fine, there are participants who are interacting. I would love to take up those question answers at the end. In case you still want me to stop at any time and have a question to raise, please do raise your hand, as Sir said. So considering that the housekeeping has been completed, let's move on to our presentation. So I'm sharing my screen right now, and I'll be then switching off the video. Just give me a moment, please. All right, and the video will be okay. Can I have confirmation from someone that you can see?
Yes, ma'am. Yes, ma'am. We can see you.
Yes, ma'am.
Right, and the video is stopped?
Yeah, yes, ma'am.
Okay, fine. Yeah, so let's start on with the main topic about the failures. This is really a very, very favorite line of mine, that irrespective of the resources you have in life, they're useless unless you know how to utilize them. and something really that you can take it forward with you, because it really gives you the kind of success if you know exactly how to utilize even the minimalistic resources that are available to you sometimes. Today, as I mentioned, the topic is failures in composites. And what we'll typically be covering is your post-op sensitivity, something to do with shade matching, demarcation lines, fractures and debondings in composites, and discoloration. These are just but a few topics, just the headlines. And actually talking about failures. What are the failures and challenges? Why do we face those in the composite restorations? Now, something very interesting has been said that a failure to closely resemble natural tooth in aesthetics and function in your composite restoration is often due to lack of skills or techniques when using resin composite. So please note that one of the most essential aspect of success would be your skills and technique. I will go a step further and say that I think the third attribute is using the right material. If you have the right materials, the skills, the techniques, I don't see any reason why you should not come up with any successful treatment modalities. But having said that, I also know most often than not, when we go wrong, we always looking for reasons. We're always looking for excuses to blame somebody. This just in jest, of course. And let's now concentrate on the specific problems that one might face with composite restorations. Very commonly, it's seen people talk about discoloration. They say shade matching doesn't happen properly. Sometimes there are white lines, even black lines. There could be white spots. There could be, the composite. I'm not able to adapt it very well. It's very sticky, etc., etc. But I think over here I'm missing out the most common issue that is faced by each and every one of us. Any guesses? Keep putting your answers in the chat box, definitely. Is there any way that I can see the chat box along with my presentation? Just give me a moment. All right, so I've given my answer already to you. So the post-op sensitivity, I think, is at the top of the list. I think most often than not, the first, the biggest, and the maximum complaint with composite is post-op sensitivity. The others we realize can be on and off, but one thing that really bothers most of us is the sensitivity. Let's look at the reasons for the sensitivity. Polymerization shrinkage of composite is definitely, one of the leading reasons. Improper lining or sealing of dentinal tubules could be another reason. Obviously, your isolation, how well there is, you have isolated, lack of contamination, etc. Your proper etching and bonding, very, very important. And we're going to discuss all of these in details. This, I think, really is something that we neglect. Abusive cutting and excessive heat generation while tooth preparation. Trust me, I have read so many studies which show that this particular reason can surpass all the other reasons and the most neglected aspect of what we do. For some reason, our burrs are favorite objects in the clinic. I've realized we do not have the inclination of throwing away burrs. Once they start deteriorating, once the cutting surfaces become smoother, we are supposed to throw the burrs. Actually, burrs for crown preparation should be used new burr per tooth, and for your restorations, at least maximum a burr can be used is probably for 2 to 3 teeth. But I'm sure all of you will agree when I tell you that for months together we continue using burrs. That of course leads to if it doesn't have the correct abrasiveness, we put more pressure on it, there's more heat generation, and this is one of the biggest reasons of post-op sensitivity. Trust me, one of you might neglect this thought, but it goes a long way in controlling your post-op sensitivity. Of course, the solution to this is keep changing your burrs, get good quality burrs, and always be assured that these are sterilized properly. Now let's look at the other points like the shrinkage to the lining and etching and bonding. So basically, we all know that shrinkage could be the effect of your material. All right, and material, one always thinks I'm sure right now in the college you are given few materials and by default you use those, whatever is available. But once you start practicing in your own clinics, so for those of you who are already practicing in the clinics, would realize that we are spoiled for choice. There is a array of materials that is available to us. Right from, I will say, you'll get a syringe of 500 rupees to a 1500 to a 2000 rupee syringe, etc., etc. So there is a wide array of materials available. What do we choose, when, and how becomes now very, very important. Right now, as I mentioned, in college, maybe there are specific choices and not rather not much choices, but as you move forward, get into your own private practice, rest assured it's going to be a big challenge understanding what kind of material do we need to stock. Inventory management is one of the biggest contributor to successful practice. Another topic, of course. But coming back to this, what material would you select? Of course, the most common answer that we get in, especially from clinicians, is something that is economical, something that is aesthetic, something that is having good, shade availability, etc. So the best way to choose your materials is based on the components, all right? And each component would fulfill a need that is there when you're doing your treatment. So selection of composite basically, ideally, you should consider the biggest point is the filler, the type of filler. We have the resin and the filler. Not much has changed in the resin technology in the last 10, 15 years, but the fillers have undergone a absolute range of changes, right from this micron size particles that we used to have to nano size particles. So your selection of composite, what are you looking for is one is the high strength, your wear resistance, and curing shrinkage. All right. So all these become very, very important, and I'm sure these are what you're looking for. But besides that, today our requirements move beyond to color matching and stability. We want polishability and polish retention. Of course, we want that lifelike effect, the translucency effect. So we cannot forego of any of these. Now, how are we able to match the material to these properties? And that becomes very important. So just right now, of course, we'll be discussing more on the shrinkage aspect, but there are many other aspects that are affected by your overall filler type that is used in the material. Just to take you back a little bit to the previous years, your fillers, of course, are ranging right from micron side, as I told you, to your first there was this hybrid material where all the particles were micron size. Then came your micro hybrid, where the particles were kind of different sizes, could be a little smaller, could be larger. So they still stayed within the range of microns only, though that was micro hybrid. And then came the nano materials. Nano materials basically 1 micron is made of 1,000 nano size particles. All right. So you can imagine the difference. And now we have materials even as small as 20 nanometers. If you can understand what I'm saying, 1,000 nanometers is 1 micron. From that size, we have gone to 20 nanometer size particles. Of course, we all know better, bigger the particles, higher the filler loading, greater the strength, but it does not give you good aesthetics. The polish retention is very, very poor. If you have the smallest size particle, of course, then you're losing out on the filler loading, and then we are compromising on the strength. Of course, in between, there was something called microfills also, wherein the particle size was in submicron size. The same concern that because the particle size are so small, aesthetically very, very good, but the strength was very limited. When the nanoparticles came into being, what was done was some micron sized particles were combined with some nano sized particles. So when I have a combination of these two, it's called nano hybrid. And now there are materials where there are no micron sized particles, only nano sized particles. They are called true nanofills. Concern would be, we have been speaking about how small particles will not give you higher strength. Technology called gel cell technology is being used, and I'll just show you an example of that very quickly. I was talking about the microfill, which is submicron, then the nano composite. I'll just show you the nano hybrid and the micro hybrid, the different kinds. So nanotechnology is basically when one of the dimension of your nano block is up to maximum 100 nanometers. All right. So a particle size which is maximum up to 100 nanometers is considered to be a nanoparticle. Please note, if I say it's 300 nanometers, which means it's zero point 0.3 microns. Please note, it's only up to 100 nanometers that the particle can be called a nanoparticle. Now, there is a difference in this. As I told you, a micron size particle, look at that, and then look at a nano size particle. So it's literally from a football to a small, not even a pebble, like a mustard, a rye. Okay. So what is the difference between nanocomposites and nanohybrids? Nanocomposites have 100% nanoparticles throughout the matrix, whereas nanohybrid will have combination of micron size particles and nano size particles. But our concern, if you remember, was if I'm going to have 100% nano particles, how am I going to get my strength? So for that, I told you about the solid gel technique where the nano size particles, okay, they are silent treated, and these are then either they are clubbed together and then silent treated, or individual particles are silent treated, and then these clusters are then put in your resin compound, which gives rise to the nano cluster. Now, let's understand each and every particle in this, whether be it a single particle or a cluster, the individual particle size is 20 nanometers. But what happens is, because of this cluster creation, I am getting effectively a size of a micron particle, which gives me higher filler loading and strength. So now I'm best of both the worlds. I've got the aesthetics because of individual small particles, and because I've got a big particle here overall, I'm getting the strength and the higher filler loading. So this is what I was talking about, nano cluster and individual nano size particles. This is a very interesting picture. This will give you an idea about exactly what I was speaking. This is a nano cluster, okay, but individual size is nanoparticles. And if you look at this, would you not believe that this is a very, very high level of filler loading, thus satisfying your requirement of for strength, and also because of the individual particle giving you that polish. So what happens is, in nano cluster, when the particles, obviously we know wear and tear over the period of time, the particles get plucked out. A small particle getting plucked out, the overall finish polish is not really hampered. But when a big particle gets plucked out, the overall finish polish is highly compromised. So that is the advantage of having nanoparticles in your restorative materials, especially if it's a 2 nanofill, it works out much better. All right, that's the 350 XT. I'll also tell you some materials regarding, related to those particular physical properties. 350 XT is one such material. As I mentioned, there is a nano cluster. The size of the cluster is right from 0.6 to 1.4, but the individual particle is 5 to 20 nanomicrons. The filler loading as good as 78% is considered quite good and efficient. I was talking about this particular situation. As I mentioned, we were talking about the shrinkage, and shrinkage, anything under 2 is considered a decent shrinkage. You'll see most composites right now that we have do have good shrinkage properties. But please note, there are also composites in the market which have 2+ shrinkage. All right, so be careful about those. Also with respect to aesthetics, the advantages, these materials are available in various opacities. Of course, if someday I get an opportunity and get a chance to get together again, how to restore the interior restoration, give the best aesthetics possible is another huge topic by itself. That is where you utilize so many opacities, and probably one day we get an opportunity to discuss that too. Another material is the 250 XT. Now this is a nano hybrid. Nano hybrid, which means which has the nano particles also and the micron size particles also. That is the 250 XT. The filler loading over here is 82% because some of the particle size are 0.1 microns and above. Okay, so this is the reason it's called nano hybrid, because there is a micron size particle in this. But the advantage of 250 XT over all the other nano hybrids is the only nano hybrid which also has nano clusters. Again, it comes back to the same point, because it has nano clusters, the finish and polish is really good. At the same time, I have enough strength. If a regular nano hybrid would give you good filler loading and strength, but the finish and polish would be compromised because there would be individual nano size particles. Moving on, the shrinkage of this is 1.67 to be precise, and quite one of the best shrinkages available. All right. Now, what are the challenges which we get because of the shrinkage and the polymerization stress. Of course, needless to say, there can be debonding, staining, leakage, secondary caries, microcracks, and post-op sensitivity, which is what we were discussing. But the other, fallouts of your shrinkage could be many of these things. And let's understand one thing: when you're doing a restoration, all you see is this portion of the restoration. At the most, if there's marginal discoloration, is when you notice there's something wrong. But there are so many things that are wrong or could be going wrong over a period of time at various level in this restoration, and that is why composite restorations are considered technique sensitive. All right. Now let's look at something that typically, again, shrinkage or let's say post-op sensitivity is attributed more to your posterior restoration compared to your anterior restoration, and there's a particular reason for it. So when you're doing your posterior restoration, I'm sure, of course, we have been taught that we do not put the whole restorative material at one time. We always first put a layer of flow, and then layer by layer we put this. Now this concept is called the herringbone pattern or the VY technique, and it's very important to overcome the C factor. Of course, just I mean, I'm sure you all know it, but just to refresh it, the C factor typically will be the number of unbonded surfaces to the bonded surfaces. So typically, you'll see in your class one, the number of unbonded surfaces is 5, and this is 5. Bonded surface is 1. Sorry, so you get total of 5, the ratio, which means that class 1 is the least polymerization shrinkage. I'm sorry, this should be a class 2. That's why I'm wondering why am I talking about that. Just give me a moment, please. I think this diagram I put wrong. I am sorry about that. Class 2, this has to be. Okay, so excuse my mistake over there, but just to come back, your bonded to unbonded. So in your class ones, of course, you have your 1 2 3 4 5 bonded and unbonded, which gives you the maximum number of maximum amount of C factor. Okay, moving on, what are the ways to improve your marginal adaptation, reduce the C factor? Basically, it all depends on the placement technique, what is the adhesive system you are using, and the protocols for light cure. The placement technique we were just talking about, we have learned the layering or the stratifying technique, where we ensure that not more than 2 surfaces are bonded by the composite at one time. As I mentioned, this is a VY technique, it's called, or a herringbone pattern. It's a combination of incremental plus stratified, and first you put a layer of flow at the bottom, and then of course you have your material which will not be touching more than 2 surfaces at a time. So first you'll put this layer, cure it, then you put the second layer, again not touching more than 2 surfaces, cure it, and then again one layer which again not touching, or again depending on the depth of your cavity, you can go on and on about that. All right. So why we have been taught to do incremental technique is, of course, firstly to overcome the shrinkage properties. We are also unsure of the adaptation. If we put in haphazard manner, we do not know if it has adapted very well to the walls of the cavity. Of course, to reduce sensitivity. Then the cure, one big issue, if your light is not going to pass, why the 2 mm? Because your light needs to pass right to the bottom of where you're curing, right? So if this was my restoration, this was 2 mm depth. If I'm holding my light over here, my light should be passing this 2 mm to be able to cure even the bottommost layer. So that is, so these were the reasons. This was of course a market study that was done across some countries, and the reason at the the factors that affect or why incremental layering was done was given as all these prior reasons. All right, as I mentioned, shrinkage, adaptation, sensitivity, and depth of cure. But what happens with our incremental layer? How many of you are super thrilled when you get a class 2 DO in upper right 7? How difficult or easy it is to do that? Can you imagine the last time when you did it, how stressful the whole situation was? For that matter, any class 1 or class 2, which is quite inaccessible, where the patient compliance has to be very high, which the isolation becomes a big issue, etc., etc. We all know that we go through a lot of stress while doing our posterior restoration, right? But it also takes more time, and most often than not, I'm not able to control the contamination unless, of course, I'm using a rubber dam and my isolation is perfect. All right. And tiring, stressful. And by the end, have I really succeeded in getting an absolutely best adapted, well placed restoration? Not really. Sometimes when we remove the wedge and the matrix band, we realize there's some bleeding, and we're just keeping our fingers crossed that I hope this didn't happen before my composite was cured. All right. And again, as I mentioned, it's a blind surface where we are not able to really see it. So because of which, then came the idea of bulk filling the entire, cavity. Of course, people were not very eager to go for it because, as I mentioned, the shrinkage stress was a problem, the depth of cure they were concerned about, and the adaptation. Now, if I told you that we are taking care of all the three aspects, these three things that are really bothering you the most, what would you do? Would you still go with incremental layering or with bulk filling? I think personally, of course, since the time bulk fill has come, I am completely, I cannot imagine doing a posterior restoration with incremental 2 mm cure, 2 mm cure, 2 mm cure. Rather, I just put the flow and direct 4 to 5 mm of bulk filling material, cure it. That's it. Your the entire restoration, is as fast as 10 to 15 minutes, as opposed to half an hour, 45 minutes that we go through for the incremental layering. So of course, we need specific innovations. I told you the reason was we had very good reasons to do incremental, and today to overcome those reasons that nahi incremental karna hai, so what is it that I can do to be able to do a bulk filling? Specific technology was used, innovation was used, and I would like to show you what that was just in a video right now, because it's kind of difficult to explain it on a blind forum where I'm not able to face everybody. Just give me a moment. I'll switch on the video. Where did it go? Just a moment, please. Is this visible to everyone, the video? Can somebody please confirm if the video is
I'm starting a video, ma'am.
No problem. Okay, now I'm starting.
Technology that makes it possible. Protect posterior expands the
I'm sorry, but it's not visible, ma'am.
Okay, it's not visible. Okay, one moment, please. You could hear it, but
Yes, ma'am.
okay, just a moment. I'll see.
We can see the slide that shrink-free and stress-free Filtech bulk fill posterior.
Right now, 1 second. I will. If I stop sharing and I again share that screen, which has now, I've not started the video, but can you see it?
No, ma'am. Sorry, the blank slide is there, ma'am.
All right. Okay, give me a moment. I'll just put a hyperlink. Let me do that, please. A moment, please.
Okay, ma'am. Yes, ma'am. Please.
Okay, now on my slide, are you able to see?
Sorry, ma'am, but nothing. No, ma'am.
Nothing? Okay, now this is quite tedious. I just showed this 2 days back. It was seen, but that was on Microsoft Teams. So I'm not sure. Okay, hold it. Okay, now what can you see? Can you tell me?
Ma'am, still a blank slide is there, ma'am.
Blank
Ma'am,
slide, is it?
share your screen. Please try to share your screen, ma'am, please.
Now
Yes, ma'am.
you can see the picture.
Yes, ma'am. Yes, ma'am. Yes, yes, ma'am. 100%, ma'am. Please start. Yes, ma'am.
Okay, so that was just to showcase the technology, and now I'm going to go back to the slides. And if someone can please, Rohit, can you, Rahul, sorry, can you confirm if you can see the slide?
Yes, ma'am.
All right, fine. So moving on, that's what I was telling you about, that the specific technology that allows you to fill the material right up to 5 mm, right up to top, without having to put a top-up layer, and you can sculpt that. That is what I was showing you. So up to 5 mm, up to 5 mm, you can put it at a time, you can cure it, and that's it. That's all that is required, required in this particular material. So it's fast and easy, of course, needless to say. And basically the curing protocol for class 2 would be just 10 seconds, 10 seconds from the occlusal, 10 from the buccal, and from the lingual. So if you can do 10, 10, 10, that's it. Only thing is, please note what is the output of your light. If your light is of 1000 plus output, 1000 plus milliwatt per square centimeter, but if you're still using a halogen light, then of course this increases twice as much. So basically it will be 20, 20, 20 is what you'll be doing. So for me, if I have to put 5 mm at one time, adapt it, sculpt it, and then do curing for 10, 10, 10 seconds, I think it's like, a very simple, efficient way of ensuring that I do not have any of the issues that come along with, adaptation and voids and shrinkage, etc., etc. For class 1, of course, it's up to 4 mm. And again, you do only from the occlusal surface, that is 20 seconds ke liye. The same thing applies if it's the halogen light, which is lesser than 1000 milliwatt, it goes up to 40 seconds. But with a good light, with above 1000 milliwatt, will give you just in 1 20-second occlusal exposure, good enough for curing this. Shrinkage. This is a very interesting slide. Now, this is universal composite. Sorry, something happening here. Okay, this is universal composite. All right, and we saw a few of the composites. The shrinkage was approximately around, this was 1.67 when I showed you. There are other composites which go about 2. Now, this is a bulk filling material which has the shrinkage lesser than 2. All right, there are very few materials. If you see this, it goes above 2, 2.5. In fact, there are other materials which are bulk filling materials which also go above that. All right, so that's one advantage of bulk filling technology. Of course, very good in handling the top up surface. You can sculpt it. Marginal adaptation is very good, and the strength and polish is retained because this too has that innovative technology of nano clusters. Okay, this nano cluster is what is going to give it strength, handling, wear resistance, and polish also. That's the material I was speaking about. Okay, now moving on. So first we saw the reason for post-op sensitivity was the polymerization shrinkage of material, and hence choosing the material which gives you the right property becomes very, very important. Next, of course, we'll look at the improper lining and sealing of dentinal tubules. Now, how many of you are using liner or base under your restoration? Most often than not, people answer that if it's a deep cavity, I might do it, but not if the cavity is not deep. If I don't think there's going to be any sensitivity, I do not do a liner or a base. Now, I personally feel, and again, there are thousands of studies to show that placing a liner or a base absolutely, counters the possibility of sensitivity due post-op sensitivity. Now, typically a liner, we are going to talk about liner. Of course, base material is could be your glass ionomer, could be your resin modified glass ionomer, etc., etc. But the liners would be used for reducing the sensitivity. It counters the shrinkage of the overlying composite, and it gives the wettability. What I'm trying to say is actually when you're putting the next layer of your regular composite, you're able to better spread it easily and adapt it very well along the entire cavity margins. Uh, Personally, I'm not a big fan of calcium hydroxide. It shows a high solubility and it can cause long-term failures because it has a very low compressive strength, especially just the regular setting material. The light curing material is marginally better than the regular setting material, but not really to the greatest extent. In fact, today there's no need to use calcium hydroxide. I think at least we old timers continue doing it as practice that we have learned through our college days. Flowable composites are the best as your liners, of course, because you can put them at the thinnest layer possible. So typically, these also can be used to, build up your cavities if they are non stress bearing areas, small pit cavities and all that. In case your preparation has a lot of undercuts, if we are talking about the inlays and all where we are going to take impression, we cannot afford an undercut. I think your entire base you'll be lining with the flowable. And as I mentioned, basin modified glass ionomer is another good to have material for creating a base. Mind you, it's very difficult to put this as a liner. As a liner, I would rather go with a flowable composite. So typically, what happens is we know that your flowable composites have much lower filler loading compared to the regular composites. Now, obviously, lower filler loadings, we know that gives you a very much higher polymerization shrinkage. This is one point. But now there's another point that a higher flexural modulus, all right, absorbs all the forces that are applied because of the polymerization shrinkage of the composite that you have placed on top of it. So if I was saying that I want a good liner, I must understand that the liner need to have a little higher filler loading and a greater flexural modulus. Now, the combination of these two is very, very important. In this, what becomes most important is the thickness of the liner that you're getting. If your liner is not more than 0.5 mm, you would not have the concern of polymerization shrinkage. So that is why I said as a liner, I would rather use the basic flowable. When I have even a shallow cavity, I'll put a layer of flowable and then I'll put the regular composite. Of course, it's a very deep cavity, very high caries index, and too much of sensitivity, etc. I might also, of course, go for the resin modified glass ionomer. Not plain glass ionomer, I prefer the resin modified version. Right? The liner, when it is placed on the pulpal floor, has C factor of just 1. So again, the C factor of the restoration gets reduced. and less gap formation, less cuspal deflection, etc., etc. So a liner goes in a long way, to take care of other issues that might arise overall with respect to your composite restoration. This is the flowable I was talking about. And of course, we have discussed these properties, the marginal adaptation, the flow, surface wetness, no gaps are created, and most importantly, the dentinal seal happens perfect. If you're placing your regular composite, and let's say there's a void that happens right along the pulpal floor or the axial wall anywhere, naturally, the dentinal seal is not maintained, and that also can give rise to your post-op sensitivity. Okay, so far we have considered, actually this topic is has many the reasons for failures are a lot. I've tried to club up the most common reasons, and so we have to move from one to the next reason. Each of these actually comprises a separate lecture. So most of the workshops when you're doing, let's say if it's a procedural workshop, so we would like to first discuss the theory for some time, and then of course get into the the practical of it. But this particular topic, as I mentioned, is more theoretical, because one by one we need to just eliminate the reasons for post-op sensitivity. So I hope this is not getting too tough or too what do you call it, uninteresting for you. Remember
No,
the post-op. Sorry.
no, ma'am.
All right, fine. So I think one of the biggest constraint with webinar is we are not facing the audience, and there's never a way to know, what the reaction is, if the participants are like, accepting the discussion, not accepting. I hope that is not the point over here. As I mentioned, please do feel free to put whatever you want in the chat box, and we'll try to look into that topic definitely. Okay, so moving on, one big reason for post-op sensitivity is your etching and bonding, okay, besides the other reasons that we have seen. When we speak about etching and bonding, again, this is a big topic by itself. Quite a lot of details need to be understood, which obviously we overlook once we start doing clinical practice. Etching and bonding is one of the primary reasons, again, for post-op sensitivity, besides the other reasons that we have seen now. If I ask you what etching bonding you're doing or what generation bonding you're using, I'm sure most of you will come up with fourth generation, fifth generation, sixth, seventh. I don't know, there are these days ninth, 10th, 15th, whatever generation. And by the way, generation is very good for purpose of academics. There are questions asked and you have to answer those. But essentially, if you're looking just purely at the clinical aspect of it, your etching and bonding is only of three types. Okay, you either do a total etch, you do a self etch, or you do a selective etch. All your etching and bonding comes under these categories. I'm talking as far as, so in your clinic, I mean, typically again, when you're, let's say if you were to ask somebody, give me a fifth generation bond, probably yes, of course, when you're buying it, you might need to say, but if I was talking to a colleague, I would say, oh, I either do a total etch or I do a self etch or a selective etch. It's no sense talking about generations, because now, as of now, this definition of generation has become very fuzzy. I mean, there are 8 generation, 9 generation. I'm sure there will soon be 15 generation. It's impossible to remember 5th generation kya karta, 15th generation kya karta. So let's suffice to say that there are 3 ways of doing your etching and bonding, right? Of course, again, a little bit of theory, just trying to refresh what you already know definitely. So in case of my total etch, what exactly I'm doing is I'm of course putting an etchant on my enamel, all right, and the dentine. How it reacts with my enamel is in this way, okay? The enamel, moment you etch, obviously the microsurfaces are going to be created. When I apply my bond on this, the bond will percolate inside this and form enamel tags. All right. So once I apply etchant, of course, the porosities increase, and it says that basically the surface area increases almost as much as 2000 times. All right. And so the bond that you get when you etch the enamel is much higher. If you're understanding what I'm saying, once you apply etch on the enamel, the surface area increases so much that when you apply the bond and the bond tags are formed like this, it's a very strong bond. So enamel bond as such is considered a very strong bond. Now let's look at what happens when you apply it on dentine. Of course, structurally we know dentine has the dentinal tubules and the peritubular area. So when you are etching, what happens, of course, is the smear layer is removed. Naturally, the dentinal tubules are opened up. But even in the peritubular area, whatever the surface demineralization is also happening. So now I've got this entire open surface. When my bond percolates inside, it has to go in all these tubules. But along with that, let's understand the peritubular area also is getting demineralized. So, which means my bond has to go into the dental tubules and also in the peritubular area. This is the basis of your uh, dentine bonding. And again, one of the top reasons why you get post-op sensitivity. Now, basically, this all depends on the technique. What happens is when you're etching and bonding, you're etching, then rinsing, and then drying, right? So when I'm etching and rinsing, okay, but when I dry, if you over dry it, what happens is these collagen fibers will collapse and you'll only have this dentinal tubule opening, which means my bond will only enter the tubules. And of course, it will form a good bond tag or a resin tag over there, but it will not be going in these structures. All right. So overall, the bond strength is low. Please look at this figure. It's very important. Now, these are my dentinal tubules in which the bond has gone. This is the hybrid layer. That means along with the tubule, it has also gone in my peritubular area, the collagen fibers. All right. And then this hybrid layer, a good hybrid layer is what will never give you post-op sensitivity. And this becomes very, very important. So dentine etching and bonding is a technique sensitive thing. It's 100% up to you. If you have not rinsed and dried it properly, if over drying हुआ तो collagen collapse होता है, under drying हुआ तो it'll have so much of fluid in it that basically your bond will not be able to percolate inside this, or the overall immersion of the bond inside the tubules is not good enough. But in self-etch, though it is considered a weaker bond, it's still considered by some as a better technique. What happens is in self-etch, your post-op sensitivity is taken away because now you're not separately etching your enamel and dentine. Your the bond itself will contain a MMP or MDP, depending on which bond you're using. Now, that's of course a self-etching monomer. Besides that self-etching monomer, of course, the other components stay the same of the self-etching solution. Now, this self-etching monomer, of course, what is it going to do is basically the moment it comes in contact with your tooth structure, all right, there is in the dentine, there is dental fluid. With this, it combines, there's ionization, and as it percolates inside, it demineralizes the tooth structure, but also the fluid which is inside is neutralizing it as it goes deeper and deeper. What I'm trying to say is the dentinal tubules that are opened or demineralized in this situation, would the depth would be not as much as if it was if you're just purely etching it. My self-etching monomer will only demineralize up to a particular level. But at the same time, what happens is the resin is going inside the tubules at the same time as they're getting demineralized, right? So because my resin and my, my entire, this is in one bottle, when I'm applying the bond on the surface of the tooth, slowly the demineralization is happening and concurrently the resin is also infiltrating, causing a good bond or rather the raising tag over there. And in this entire picture, what happens is because there is no drying step involved, etching and drying, the collagen fibers do not collapse. So the material that percolates into the collagen fibers also gives you a good hybrid layer. So overall, self-etch adhesives are considered less in sensitivity, but again, they're not considered as strong as your total etch. So just a pictorial depiction. So if I was etching, I might open the dental tubule to this level, then I'll rinse, dry, and my bond might just go to this level. The gap that remains over here, which is called a nano gap, is where your the thermodynamic theory will be functioning, and that will cause a little bit of sensitivity or pain to the patient. In your self-etch, both of them are going at the same time. So irrespective of the depth of the tubule, rest assured that my bond is flowing right up to that level, and so the sensitivity is decreased. So this is the difference between self-etch and total etch. Naturally, each one has their own technique of doing it, whether self edge or total edge. You have to decide what you're comfortable with. Having said that, of course, the best way to go is selective edge. Now, if I have enamel, I'll 100% do total edge. I think enamel should be etched. If it's a very deep cavity where I'm worried about post-op sensitivity, I might do a self etch. But then for enamel, I know that self etch is not going to give me very high bond strength. In that situation, what we do is we just etch the enamel surface. All right. Once you etch the enamel surface, just give me a moment, please. Sorry. Once you etch the enamel surface, you rinse this entire thing off, and then you take your self-etching bond and apply it to the overall cavity. Okay. Now what happens in this is basically I have already etched the enamel. So my bond will work on this just for the purpose of bonding. And for the rest of the cavity where no etching was used, it also can be used as an etching component. I told you MMP, a self-etching monomer, is mostly added to give you that etching effect. All right. So all you need to do is basically just apply it, dry it, and then cure it. Now, this is a huge difference between your moist dentine and dry dentine, which was causing the problem of post-op sensitivity. And that is why I've been saying that this is actually a technique sensitive method, especially if you're looking for total edge. Is technique sensitive. If you over dry or under dry, you will not get this kind of picture. You'll get this kind of picture, and of course leading to weaker bond and higher post-op sensitivity. So what do we do? I'll just tell you about a bond which is considered a gold standard bond. I was telling you about the total edge system. Okay, of course you can call it the fifth generation. This is mostly, I think now everybody's using from the fifth generation onwards. Very, very, very few are using the fourth generation, which had its separate bottle of edge and primer and adhesive. In fact, that was the most foolproof method of doing your bonding. But considering it takes a lot of time again and too many steps, the total edge system came in place where the adhesive and the primer are combined in one bottle. So this typically would have your resins, and it would have your filler particles. It would have a carrier, a solvent like ethanol and water. And especially in this particular bond, there are two things to note. There's something called Vitribond copolymer, and the carrier is or the solvent is a ethanol. Vitribond copolymer basically is a kind of a copolymer which, irrespective whether your dentin is dry or wet, works in that entire spectrum. What I'm trying to say is, inadvertently, if you're in your pocket, if you have over dried the tooth, not to worry. Even if the collagen fibers have collapsed, this Vitribond copolymer takes care of it. Re-wetting happens, and then you don't have to worry about not getting a hybrid layer. The function of ethanol plus water, as I mentioned, is having it's a solvent which carries the bond to the tooth. In this, there are various combinations. Along with water, there could be acetone also. So let's look at the difference. What happens if there's acetone or if there's water? In self-etching, I told you basically there is a self-etching monomer. The MMP is there in most of them. Besides that, rest of the components stay the same, and this is what takes away the need of you separately etching. That's the ad per easy one. Okay, so what is so great? Why is this considered a gold standard bond? And so much so that it is impossible that, unless of course the technique is completely incorrect, there is no chance of you getting a post-op sensitivity by using this. And that is why it's considered the gold standard. Other bonds are always compared to this bond at various parameters, all right, to check the efficiency of that bond. Now, this bond basically has 10% filler loading. I told you, and the particle size is 5 nanometer. Please understand it's 5 nanometers as opposed to some other particles which could be in micron size. Now, what this does is, of course, when I'm talking about the maximum amount of the particles percolating inside my dental tubules or in my fibers, collagen fibers, etc., I'm interested in having the smallest size particles possible. Okay. Also, what happens is because the particles are so small, they remain dispersed in the solution, unlike the bigger particles which will settle. So if you're taking a bond bottle and not shaking it, this will give you a problem, because then what you're taking to the tooth is only your solvent layer, all right, or the resin, and not the fillers. But in this, you're carrying both the resins and the fillers together. So basically, this becomes much more efficient with respect to the availability of both resin and your filler particles. Another thing I told you about acetone and ethanol. Let's look over here. The surface tension of both is similar, but the vapor pressure of ethanol is lesser, much lesser than acetone. Why are we looking at vapor pressure? I told you first we etch, then rinse, then apply the bond. And after applying the bond, we always have to dry it. Let's understand what I require of the bond on the tooth would be just the resin and the filler particles, right? My solvent, which is just a carrier from the bottle to the tooth, has no other function at that time. All right, so I need it to go away. And so we always air dry after applying the bond. How much time to air dry? Till you see no waves or no, this in your bond. When the tooth looks moist, but there are no waves that are formed when air pressure is applied, that is the time till which you dry the tooth. Now, at such time, I want my solvent to evaporate. Of course, acetone evaporates very fast compared to ethanol, but acetone, when in bottle, also can evaporate because of this high vapor pressure, as opposed to ethanol, which doesn't evaporate from the water. One. Two, when I'm applying with acetone, basically I need to apply it very quickly, and I have to, it has to be, it dries off very fast. I'm not very sure about the amount of the material percolated. With ethanol, I know that when I want it to disappear, it will go when I apply air pressure. So this is under my control. It has an air pressure, vapor pressure rather, but it will only happen when I am blasting it with air blast. All right, so that's one advantage of having ethanol over acetone. Either the combination can be ethanol with water or acetone with water. So today you'll find these various combinations that are available. Now, what should I use? Fifth generation, seventh generation, 15th generation doesn't really matter in the long run if your technique is correct. Trust me, even if your your material is the best material, but you have not done the correct technique, a bonding step is a short reason for failure if not done properly. Okay, so stick to the technique becomes very important. Again, we are spoiled for choice. We have array of materials. I told you this fifth generation silica. I don't know which generation, and I do not now understand what should I keep. The inventory that is kept in the clinic becomes very high. So obviously leads to confusion. Now basically, I'm sorry. Okay, so now basically the trend is moved to universal bonds. What do these universal bonds do is, let's understand. This is single bond universal. What it does is, whether your dentine is moist or dry, let's understand it from this picture, the wetness and the dryness of the tooth. So whether my dentine is wet, moist or dry, I need something which is not going to be affected by the underlying moistness. And this whole thing is taken care of your entire Scotch bond or single bond product line. And one of them, of course, is your Scotch bond, or it's called in India, it's called single bond universal. If I'm doing total etch, I will first etch, rinse, and then apply this bond. If I'm doing self etch, I will not etch and rinse. I'll just simply directly take this bond itself and apply. The method of application becomes scrubbing in this case, and in this case, you can just paint it. Scrubbing is required to initiate the ionization. Not just it works in your total etch and self etch, and of course your selective etch, it's also a primer. So basically it's a primer for your zirconia, alumina, ceramics and alloy. So if you want to put it under your amalgam restoration to prevent any post-op sensitivity, fantastic. Also it gives you very good strength in your crowns and all that. If you're using zirconia or alumina, anything, when you require, there is need for a primer, this can be used. Of course, it can be used in direct, indirect. I'm not getting into detail of that. But interestingly, what is different over here is this MDP. Instead of MMP, this is MDP phosphate. That means it's a self-etching monomer along with a metal primer. Okay. And again, the Vitribond copolymer, which is very patented to the Scotch bond family is there, and ethanol is there. One more addition in this is silane. I'll just take you through this quickly. As I mentioned, MDP is a self-etching monomer, but it's also a primer. Your other resins, etc., will do the same work. I told you about the Vitribond copolymer. Basically, it reduces the adverse effect of moisture, right, and it allows to bond to moist or dry dentine. Silane, of course, is required when you're doing your ceramic, your glass ceramics, etc. You need to apply a separate silane, but this has silane already, so you do not need to buy a separate silane. Ethanol and water, I already explained. Of course, the fillers are 11% by weight, and the film thickness is only 10 microns or lesser. This becomes very, very important again. And of course, photo initiators, we know they're CPQ. Interestingly, this bond is hydrophilic before cure and hydrophobic after cure. I hope you understand this is what is required to prevent your water tree effect. We require a bond which is hydrophilic when we are applying because our dentine is moist, and after curing, I want it to be hydrophobic, correct? Whether it's etched dentine or unetched dentine, we get good amount of resin tags that are developed. Some of the tape is, simple small steps to isolate would be basically using your Teflon tapes. I hope you're using this. This is a simplest, cheapest thing to be used in the clinic and does wonders, especially in your anterior restorations. It can also be used to separate the two teeth. When you're doing your etching and bonding, you must ensure you're applying this because that way you're protecting your adjacent teeth. Most of us do not take this care, but it's a very small thing. It hardly takes 10 seconds to apply this, but it will go a long way in protecting your adjacent teeth. All right. Next is, of course, you can either use a dry brush to remove excess, but I'm not a big fan of this. I prefer to air blow and dry it after application of the bond. This is the post bond application. Okay, so either you take a dye brush and dab away the bond, or you just do air blast. I prefer the air blast personally. Okay. In your selective etching, again, one small tip is if you don't want, it's very difficult to make out in the tooth, on the tooth rather, that you know how much is the enamel and dentine, and you don't want this to reach to your dentine region. Just take a small Teflon tape, make a ball of it, push it into the cavity, leave just the top surface open, and then etch this portion. And then when you're rinsing, if you remove that small ball of Teflon, what you get is a etched enamel and unetched dentine. Okay. Okay, I mentioned about the scrubbing action, very much required in your self-etch and your selective etch. Just a picture of total etch, what it looks like. So when I have maximum enamel, I will by default go to total etch. Some of us fear that total etch is going to give you too much of sensitivity. Next, I will try as much as possible to do the selective etch. And if these both are going to be a concern, only then I personally move to a self-etch. Having said that, if you have the good material and good technique, trust me, really, you could be doing absolutely fantastic with all the three systems. With respect to sensitivity, as I told you, 0.06% sensitivity. That's it. So negligible, or rather zero. Moving on now to our next, we also saw there were other reasons or failures that we encountered. Of course, we looked at the polymerization shrinkage at this topmost reason. In polymerization shrinkage, we saw the materials, how they affect the filler particles, etc. Then we also looked at our, the liner base that needs to be applied and those properties. Now we are also moving on to the shade matching that we spoke about. A big concern with anterior restoration is many people say, I start off with the correct shade, but I never, eventually after curing, when I see the final restoration, I do not get too much of shade or color, or rather it's a mismatch. People also get a lot of discoloration. I'm sure you might have noticed sometimes white or black lines. You could notice white spots, and typically some of us are not very happy with the consistency of the composite. So just let's look. While these might not be the major points, but still they will lead to a failed restoration, at least aesthetically. Now, aesthetically, again, I'm sure if I asked you in your anterior restoration, what is the one thing that bothers all of you the most? the answer would come out as demarcation line. Of course, debonding and those things are there, but I think demarcation line is a problem to one and all. And the interesting aspect of this is demarcation line is sometimes very, very visible at the end of your restoration, when you've finished, polished it, and sometimes you don't see it at all. So throughout the restorative procedure, till your finishing polishing is done, in some way, I'm keeping my fingers crossed, hoping that when I finish this off, I don't see the demarcation line. Now, that's of course not the best way to go about it. If we understand what this line is, we can also ensure how to remove it. And what is this line basically? This is where you placed your bevel. Now, your bevel appears as that gray line or that stark demarcation line between your restoration and your tooth. Just understand this, consider, imagine a anterior restoration is fractured. I have beveled it at the fracture level, and I have, restored the rest of the remaining part, the fractured part, with a composite, which means now I've got specifically a tooth portion and a composite portion. Now, naturally, my tooth and composite are meeting where I've made the bevel. Now, this meeting point of tooth and restoration is very, very evident when you see it with the naked eyes. Why is that? Because if whatever said and done, you could use the best of material, but the optical properties of your tooth and of the restorative material are always going to be slightly different. So when my eye looks at your tooth, which is restored, I see the tooth showing me different optical properties versus the restoration. So I can make out there is a difference between these two material. Hence, I can make out the demarcation line. So specifically, when you give a very, very clear cut, shallow bevel, this is the thing that will be the biggest challenge. But your bevel is basically, if you're not considering your margins properly, if they're sharp, if they're not finished, if they're not polished, they will definitely give you the kind of demarcation line. Now, this is a good bevel. Please note over here, if you see there is no sharp surface anywhere. This is a two-plane bevel, and I'll talk about it shortly. But if you notice, there are no sharp points. Actually, you use your finishing polishing burr at the end to finish off your bevel. If you get into the habit of finishing off your bevel, you will rarely, if ever, see this demarcation line. All right, this is one point. Again, as I mentioned, it can be a long bevel or a two-plane bevel. Typically, a short bevel will give you that problem. What do I mean by long bevel? We know that we give the bevel we give is 45 degree, right? That constitutes your long bevel. In two-plane bevel, what we do is, this is my long bevel and my burr will be held like this. Then I straighten the burr a little along the long axis, and then I make these shallow, imperfect lines into the enamel itself. So now I've got two planes. I've got this, and then an angle is formed, which is this. So now when my material comes over this surface, the thickness of my material is different at different level. It'll be thickest over here, but as it comes here and then here, it thins. That means my material is merging into my tooth, all right, along these imperfect lines that I've made. And that is why my eye is not able to make out that there's a very specific categoric cut line there my my tooth ended and my composite started. So this basically is also called bevel into infinity, wherein I'm making this a long bevel along with a longer bevel but a much shallower bevel on my enamel. So this kind of bevel basically gives you that kind of freedom where you get a lot of space. Of course, your surface area also increases, my availability of enamel also increases, and so giving me higher bonding, etc. And at the same time, I do not see that demarcation line. Moving on, I told you that finishing and polishing of bevel is the most important part when just before you're applying your etching and bonding. Do this step and trust me, you'll never get an issue. I particularly like to do it with the disc because disc is one safe side. So when I'm doing the polishing over here, if I take a burr, my hand slips and goes into this, touching my adjacent tooth. But if I have a disc which is safe-sided, like one side is abrasive, the one facing towards the tooth is abrasive. The moment I turn this in between these toe teeth, I know that my non-abrasive surface is going to touch this tooth, so my adjacent tooth is protected. I'm very, very particular and very big, this of that when you're treating one tooth, the other tooth should not know something is being done. We very rarely take care about isolating the adjacent teeth, not letting a bird touch the adjacent teeth. That's, I think, personally, I think it's a disservice to the patient. That is not fair that you're doing that, because the patient never came to you with this tooth problem, but after some time, he'll definitely come to you. So let's not do it. So these are small, small things that can take care of such things. So I told you about the demarcation line. Having said that, most often than not, we also find that we're not able to do shade matching properly. Just let's look quickly at some of the aspects of aesthetics. Overall, your aesthetic depends on three things: your tooth shape, finally that you have attained with your restorative material, the surface texture that you've given, and the color. Please note that the principal factors affecting this in order of importance, which means that my tooth shape, the shape that I give to my final restoration and hence the tooth, is the first important point which will give the right aesthetic. Second is the surface texture, and third is the color. Most of us, the moment the patient sits, we remove the Vita shade tab and start looking what shade will match, not really paying attention to these aspects. Now, this basically, of course, is when you're restoring the tooth, you need to take care of all these. So first and foremost, look at the tooth shape. Again, of course, this by itself is a huge topic. Just very quickly, the tooth shape, we all know the principle of smile design. So whether you're doing a single tooth or multiple teeth, we need to maintain those principles of smile design. So if my tooth shape is mimicking my adjacent tooth, by itself, it gives me a very high aesthetics. Second is the surface texture. Now, basically, if my tooth has this surface texture, recreating those textures become very, very important. And theoretically, there are three types of texture: primary, secondary, and tertiary. I'll not go into detail of that. There are just few things that, again, this is something that I really talk more during the demo, because it's quite difficult to explain how this is. But let's look at this tooth. Now, this is the tooth that was restored. Okay. Now, can you make out these lines? This. Now, the actual mesodistal width of the tooth is from here to here, right? But the apparent mesodistal width of the tooth is from here to here. Now, this is what will give you the proper shape and the proper angulation. If I made the tooth which appeared this wide, I would not have an identical tooth. So please note the transition lines are the first thing that you need to look at. Okay, if I place a transition line properly, most of my work is done. Then you get into your secondary and tertiary. If you can, of course, for our anterior teeth, the developmental lobes, the grooves, the pericymata, the imbrication lines, all these will constitute the tertiary characteristics. How to do it, of course, again, is the technique can only be done demo or hands-on can be done, but theoretically, all I can tell you is you should ensure that these things are maintained. How to do it, of course, is another story. Okay, I spoke about these. Okay. Now, next, of course, we saw the tooth shape and the tooth texture. The third is the color. Of course, I'm not saying that you do not need to do shade matching during this, but shade matching comes third. So first, start with observing the tooth shape, observe the other teeth for the texture, the flaws in them, the probably stains, what they look like. Are they very smooth and untextured? Are they very textured and yet very high, value, etc. So once you get a picture of that, you know how to start constructing that. Then, of course, you start looking for the colors. And of course, this is not my opinion. This is just something that is being said that women are better. And this is an interesting test. Ishihara has an entire set of tests which you can go and check for on your, you can Google it over here. Just all of you, I'm asking you to check in this what figure, what number can you see? Please take a look and tell, or at least to yourself, think what number you can see. Now, those who could see number 5 have normal eyesight. Those who saw number 2, there is something color deficiency that they need to tackle with. And those who saw some other number besides 5 and 2, I think it's time to just go and visit your ophthalmologist. Okay, so some tips while doing your shade matching and all. If you can, use your colleague or chairside assistant to give you a second opinion, of course, which has to be very, very quick and fast. You cannot keep holding the tooth tab in front of the tooth for minutes together. This has to be just few seconds. You take a tab, move it, take a tab, move it. This should happen within 5 seconds. It goes really fast. If you pinch your eyes like this or squint, you can actually see a better color differentiation. Now this is your Vita shade guide naturally, and this is what we would be using. If you know the Vita shade guide, the initial few colors or rather the shades are much lighter compared to the latter shades. So another way of doing shade matching is of course putting blob of various shades of equal thickness, curing it and checking basically whether it matches. Naturally, I go this only as a final step when I'm not able to figure out the various levels at which the tooth color is can be distinguished. This of course is a waste of material. So if not sure, definitely go for it, but I would not advise that you can do it for each and every tooth because naturally that much material waste is happening. Okay, your actual shade matching is, it's all about the Munsell's category that we have been taught, the hue chroma value. The hue is the color of the tooth, the red, blue, pink, yellow, white, whatever. Chroma is the intensity or the saturation, and value is the whiteness of the or the blackness of the color, right? In teeth, we have 4 hues, ABCD. In each of the hues, we'll have various number of saturations. Like in A, the highly saturated one is the A4 and the lightest is the A1. Similarly, B may there are only 4s. D may, if you know, there is no D1 by the way in shade tab, and so on and so forth. So basically, these are placed according to the chroma. So now this tab, according to me, what you saw a little earlier, sorry, the values of whiteness and blackness I was talking about. So my tab based on the hue and the chroma is placed here, my hue and chroma. But let's understand, of course, in a theory we have learned what is the most important thing to match is the value. Value is whiteness or blackness. Now for your shade and your, or rather your hue and chroma, you have specific ways to see whether what the hue and chroma is. But for value, you cannot just determine it just like that only. In your classic Vita shade guide, the way it comes, and even in the box it will be written, everywhere it will be given, is this is the order in which you have to place it. That is B1, A1, B2, D2, etc., etc., etc. What does this mean? That my B1 is the lightest shade in my entire repertoire, not A1. Please understand, B1 is the lightest. Okay, so let's say if I taken a B2 and I thought B2 thoda match ho raha hai, lekin I want a little darker. Would I think of a B3? If I thought of a B3, B3 7 shades darker. The next thing I need to think about is a D2. Maybe again D2 मेरे पास हो ना हो, but A2 तो पक्का होगा. Instead of going from B2 to B3, I would rather go from B2 to A2. You're getting my point? Or let's say if it was B2 and I wanted a lighter shade, I will not jump to B1. I will next jump to A1, which is a little lighter, and then a B1, which is more lighter. So the way this is placed is based on the value. And if you're using the Vita Classic Shade Guide, place it in accordance to the value and match it in accordance to the value only. To counter this, of course, you have the newer shade guide that has come. The 3D shade guide is useless for your composite restoration. It's only there for indirect restoration. But the new Vita linear shade guide has come, which is purely value based. So that's not as confusing in these. But 3D shade guide is definitely not a very useful thing. So naturally, the initial part I told you would be the highest value or the whiteness and the lowest chroma. And the latter part will be the highest chroma and the least value. Another very interesting picture I'll just show you. If you look at these 3 teeth at various stages of maturation, this is a very young patient, adult, and old patient. If you see in a young patient, you will see very crisp, what do you call it, the line angles. You will see that there's very stark, appearance of mamelon. You'll see that these lines, because there has been no wear and tear, are very, very, again, visible. There's a very specific halo that is visible. There's not too much of variation throughout the tooth. Now, this kind of tooth will require different kind of shade matching. If you look in the adult tooth, you'll see that a little bit of chroma changes over the entire length of the tooth. You'll also see that the mamelons are not so well defined. There's incisal edge wear and tear that has happened. As opposed to this, in a very adult tooth, You'll see huge amount of variations in colors. You'll see a lot of staining, spotting. Mamelon is rarely if ever seen. This. So if I'm doing shade matching for this tooth as opposed to this tooth, my complete philosophy changes. When I'm shade matching for this tooth, I need to look at various opacities. I need a very specific opaque material. I need a very specific translucent material. When I'm doing my texturing, I need to do very specific developmental lobes and grooves and this mamelon structure. Whereas in an older patient, when I'm restoring this, I just need different shades more than different opacities. Of course, I require opacities also, but if I was to take a little darker and then lighter, this would help. I don't require too much of a translucent material over here. In adult tooth, of course, it's a combination of these two. So age matters a lot when you're doing your shade matching. Just because we know that beta shade guide hai, उठा के match कर ले. If you matched over here A2 shade, when you finally prepare this entire thing with the A2, it's going to look absolutely absurd. What is the next step? Finishing and polishing. Finishing and polishing is one of the highly ignored or least considered step. And actually, that's the one step which can give you maximum aesthetics. I'm talking purely from angle of aesthetics, right? When you're restoring your tooth, your restoring should not take as much time as your final finishing and polishing. Restoring is putting one over the above next layer. That's it. You edge, bond, put one layer, the next layer, the next layer, and you have cured each layer. That's it. That's all restoration is about. But finishing and polishing is actually what you're going to give the shape, the texture, etc. In finishing and polishing, there are actually now this again, it's a big topic. When I'm doing my interior restoration, we take good an hour or two on covering this topic. But here, just theoretically, I'll tell you a few points. Finishing and polishing actually comprises of these 4 steps, and these steps only, and 100% these steps. First should be a gross finishing or excess removal. Second should be a contouring. Third should be a fine finishing, and then should be a polishing. I'll tell you why I'm specifying on this. Here, of course, हमने theory में पढ़ा है. Most often than not, you'll see what you start doing is after preparing, you feel, oh, ये थोड़ा excess है, तो चला मैं excess नहीं. But when you're removing the excess, I suddenly realize, I think it's a little longer. ये यहाँ पे over contoured है. Let me remove that a little bit. Oh, this is looking a little bit out of shape and out of angle. Let me remove that. Then I feel, okay, fine, ये ठीक लग रहा है. Start my polishing, or rather finishing at least. Once I'm doing my finishing, again I notice somewhere, oh, it still has excess there. I again go back to my excess removal, because let's understand, for every step, different grit of material or burr is used. Let's understand. Okay, so we use the most abrasive grit for gross finishing. Contouring will use a medium grit. We'll use a fine grit for finishing, and a polishing clay will be using something which is more like which gives you a glass-like gloss. So glossing is last. Now sometimes when I'm doing my this step, I suddenly notice, oh, there is a little bit of excess left at a particular place. I then need to go back to this step. But then again, I need to come back to this step and then this step. Suppose when I'm doing my finishing, I notice that still there is excess. I'll go back to this step. Then I'll come here and here. The reason I'm saying this is all the polishing systems you'll see in the market now, and there are too many of them, they have a specific what do you call it, order in which you have to use. They could be anything. They could be, pink, blue, green, yellow, and then the particular manufacturer will tell you that first use the green, next use the yellow, next use the whatever. So you need to know what color is what. Is it for your finishing? What is the grit of that? Is it for your contouring? What is the grit of that abrasive particle? For your finishing and polishing. Once you know this, you don't have to remember and keep going back and understanding, oh, I need to follow this color scheme, I need to follow that color scheme, and I don't know kiske baad kya. And trust me, I've seen people who are doing, finishing and after that doing contouring and then just directly going to polishing, because it's difficult to remember that in a particular order unless you're very well used to that particular polishing system. Now, having said that, there are few do's and don'ts when you're doing your finishing and polishing, which I'll cover. Before that, I'll just take you through this polishing system, and I swear by this polishing system purely because I really found nothing better than this. And trust me, I've never used I'm sorry, I'll just plug in the partner. I've never used a burr for my finishing and polishing, not even for my excess removal. Right from the excess removal to the final step, I use only the soft lace disc. Okay, I hope you can see my screen again. So this Softlex polishing system, and I did tell you there are many polishing system, not an issue, whatever is your choice. I'll be talking about this one. It comprises of 4 discs, again color coded, dark pink or red, what you want to call it, light red, a dark yellow and a light yellow. So that's so what I'm trying to tell you is these are various grit. By grit, I mean the abrasiveness of this. This is most abrasive. It literally cuts through the tooth, whereas this actually gives you the finish or the glass polish, basically. So this is the Softlex system, which has 4 coarse, medium, fine, super fine to be used in this manner with a mandrel, of course. And there are 2 of these that have come up, the spirals. They are absolutely another level of finish and polish. Coming back to theoretically, why to use what when? So it has been found out in studies that the occlusal, of course, we know that, I mean, the occlusal surface has its own undulation, right? It is never flat, straight surface. In NTS, we encountered quite a lot of flattish surface, but in our posteriors, the cusp, the grooves, the marginal ridge, etc., all of that makes for a very undulated surface. All right, and if most often than not, we just remove the high points and we send the patient off, not realizing that it's the biggest cause of attracting your plaque. And obviously, if there is marginal leakage, secondary caries, etc., and discoloration, of course. Now, there is a system that I told you about, Softlex Spiral, which is basically the combination of all these discs, etc. It looks like this. It's a hybridization, so to speak, of point, cup, wheel, brush, etc. And this spiral, one is the finishing and one is the polishing. The finishing one is coated with aluminum oxide, as are the other Softlex discs, and the polishing one is coated with diamond particles. Okay, so basically, instead of going through this entire system of so many things, you just replace this whole thing using just one finisher and one polisher. So I remove my high point, I take my finisher. Now these are soft. Okay, I showed you the picture. These are soft. These are elastomeric material. They actually go into each and every groove that you have created, and so there is no surface irregularities, and I'm talking of microscopic level. And once you have polished it, that tooth will not attract any plaque or anything eventually. That's the polishing system I was speaking about. As I told you, this has to be followed in the coarse, medium, fine, super fine, and then finish it off with a diamond. Or I could just take a finisher for posteriors. I would do a finisher and then a diamond. These are paper backed, and these are polyester backed. This is, of course, more commonly available now. Okay, as I was talking about, because of the soft this, it goes into every nook and cranny that is required. Okay, some of the tips, as I was telling you, I never use diamonds. Diamonds are known to pluck out the filler particles and leave a very rough surface behind. Now, basically, I know most people say for excess removal, I use diamond, but not really advocated for your anterior restorations, for your composite restorations. Carbide burrs are much better. Having said that, carbide burrs, one, are slightly premium priced, and two, are you need to really get a hang of it. Otherwise, it just slices through the tooth. So you need to get a good control if you plan to use carbide burrs. Discs are always better than burrs. I also showed you one of the example where I showed you how the disc will have one surface which is a plain or non-abrasive surface. So when I'm taking it for the interproximal finishing polishing, of course, I prefer my disc because my burr is going to touch the adjacent tooth. Also, the disc gives me larger command over larger area as opposed to a burr. So when I'm passing my burr over the restoration, I tend to, if my hand slips a little bit, I tend to create a notch, which doesn't happen with discs. All right. And you should always finish and polish from the restoration to the tooth. Of course, there is theory behind this. Unfortunately, I cannot show it to you right now. And follow every specific step in specific order. So as I mentioned, it has to be your excess removal, contouring, fine finishing, and polishing. Okay. Select a material by itself, which will give you a very high finish and polish and a high polish retention. I was talking about I'm talking about the material which contains the nanoparticles. Especially if it's a true nanofill, you have unsurpassed polish and polish retention. And even a nano hybrid should give you a better polish compared to any other hybrid material. Okay. Rahul, can you just tell me how are we on time? I'm sorry, there was no closing time given on your Zoom meeting this. So what was communicating? Can you just please tell me?
Ma'am, you can continue, ma'am. You can continue, please.
Okay, I hope the audience is okay with that and don't get too angry with you, Rahul,
No,
for saying that. Okay, I will just take quickly another probably 10 minutes. Also, I'm coming to a part which is my personal favorite as a topic of lecturing, and I do a lot of workshops and lectures on this. In fact, I've gone ahead and done special studies in this topic, so I feel very good about discussing it. And let me tell you what that is. So, for your good restorations, we have till now come up the main factors. One, of course, would be your good quality composites, right? Again, would be your etching, bonding, material, and technique too. And there is a third factor, and this third factor is, trust me, actually the most biggest reason for failures. Anybody who can put it in chat box will get a prize from me. While I cannot see chat box, Rahul, if you can see and somebody's answered, please tell me. Anybody? So for last 7, 8 years, a part of what I'm doing is also complaint resolution. Whenever I get a call from any dentist saying that, you know what, this material debonded, or patient is having a lot of sensitivity, oh, it's discolored, I don't like this material, this, that. So there's a lot of blaming happening. And initially, of course, I used to be very worried. What do I tell people? How do I explain to them? No, you need to recheck your technique. It's very difficult to, point out somebody's this. But eventually, I came up with one very good question, and the answer to which tells me what can be the issue with the overall respiration. Any guesses? The third thing that is required for successful composite restoration. Rahul, any answers you've got? In the chat box?
in the chat box, there's no answers here.
Oh, sad. Okay, guys, it is your light curing. Okay, a topic which hardly gets 10 minutes of mention throughout our academic years is actually a topic. There is actually a company which studies, does research on light cures. That company is called Blue Light Analytics by Dr. Richard Price. I've had the good fortune of meeting him a couple of times, going through entire session with him and listening to his lectures one-to-one. And I realized light curing is a huge topic, probably can be half the syllabus of our direct restoration or indirect for that matter. Light curing is huge. I'll tell you what, we do not pay attention to light. And there are very specific things that are required. Of course, I'm not going through the entire theory. I'll just tell you 5, 6 pointers, what is required when you're doing your light curing and how do you select. Do you guys know, I'm sure you must have gone to the various conferences of, where you find somebody selling light for 2,000, some other stall pay the light is like 50,000, somewhere you even see a 1.5 lakh light, and you wonder what is this, and you we are under the impression that when I'm starting, I should start with a 2,000 or 4,000 light, and when I get very well established, now that time I'll go for this higher lights. Friends, absolutely wrong way of selecting your light. Please, 2,000, 4,000 ka jo lights hai, those are like torches. And I'll tell you, I'll explain to you why. And I don't mean everything is financially this. I'm just giving an example. Okay. Am I saying that the light which is 1 lakh is the best light? No, that's also not what I'm saying. You need to know what to look for in your light so that you get the best possible properties. And that is what I'm going to tell you. So whether you buy, if your light has all these properties within 2,000, or the light has these properties in a 2 lakh light, you go and decide. I'm just going to tell you what are the properties that you need to look at. So essentially, of course, we all know what is light curing and why it is important. I told you, something, your maximum income. And over here, again, I'm getting a little, talking about the money and finances, but our income depends a lot on light curing, almost 50%. Again, I cannot go in depth and tell you where this has come from. These are, of course, surveys and studies which are done. For how many of our procedures in a clinic we require light? Almost 85% of our procedures. So 100 procedures we do, 85 of it requires light, out of which 50% of your income is dependent on the proper light curing. Okay, and every clinic should have a light. There are times when we always struggling, oh, I'll not buy this light, I'll not buy that light. And in fact, for the material also, we are always thinking about, of course, not now, probably in college, but later on, you'll come out and say, you know what, this material is 5 grams for 1,000 rupees. This material is 4 grams for 1,200 rupees. And I've seen this so often. And people break their heads over material cost, material is that. Inventory management, I told you, is one fantastic topic. And if you can really capture the essence of that, trust me, your earnings will multiply. Just to give you a pointer, this is of course calculated in dollars. So in this study, how did they come up with this? So there was a filling which cost, let's say, 200 rupees to the dentist, out of which they found that $120, sorry, was basically going in his overheads. Okay, only $19 was the cost of your restorative and disposable material, and out of which only zero point 0.4 was the cost of your life. Okay, what I'm trying to say is when you're looking at the bigger picture, let's not think about materials and light and equipments which are going to save our money. Not happening. These are the things which will get you more money. Better material you use, better equipments you use, latest techniques you use. You can always charge more. You can have three huge LCD televisions in your clinic to make it very good. But if you don't have the correct equipments or material, it's not going to help you. I would rather be spending on these things than spending on things which are not going to give me the fun. Of course, if I have money, I'll spend on both of them. That's another matter. So, uh, 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 so basically, lights, when they were checked again, 73% of lights required testing. These are all studies, okay? I have the reference to these studies. Anybody interested or anybody your this MDS thesis in lights or something, please reach out to me. I've got a lot of data on lights. Okay. Now, basically, doctors do not mostly realize that light can be the reason of the failure, and most often than not, your poor performing light is the reason for failure. All lights are not same. Even from one company you buy two lights, they will show difference. Curing lights always degrade over the time. So I bought a light which was showing me 1000 milliwatt in year one. Probably by year 3 or year 5, it would show me a lower intensity. And that light intensity also drops over distance. I'll just show you quickly all these few examples. What am I using light for? Basically, light is to activate your photoinitiator to set up the polymerization reaction, right? And if my material is not cured properly, everything gets affected, right? From all your mechanical properties, your wear resistance, fracture, discoloration, staining, of course, debonding, so many things. So basically, light is one thing that takes care of the overall. So you be using your best lights, best materials, but if you don't have the right light, you will not get successful. And that was what I found out after I studied this light curing concepts with the blue light analytics. After that day, anytime a doctor has any concern or a complaint, I always ask them, when was the last time you have checked your light, doctor? And that gives me an answer. If the doctor has not checked his light, and trust me, 99% times nobody checks their light, I know the reason can be that. So I always start with light. I always tell them, please get the light checked for intensity, for other problems. And if that light is correct, yes, then we'll look at the problem or the material or the technique. Okay. So what are the key factors that affect your light is first is the photoinitiator that is being used in your product, and second is the wavelength. Now we all know photoinitiator that is typically used in our composites is CPQ. Very few of them right now coming in market with the ivosirin, TPO and all that still has to undergo a lot of research and study. There are many issues with that. So most manufacturers have stuck to the CPQ as their basic photoinitiator. Why is that important? Because basically your light will activate this CPQ, right? The photoinitiator to set up the polymerization reaction. And this basically, at what wavelength it will do is 400 to 500. So CPQ requires 400 to 500 nanometer to initiate it or to make it get into the reaction. So to activate it, CPQ requires 400 to 500 nanometer, which means your light should be within this range. Now you'll see sometimes the light are outside this range. There are lights which you'll get from 300 to 600. So why not that? Now 400 to 600, if you see in a light spectrum, the white light is made up of 7 spectrums, right? The blue spectrum is the 400 to 500 nanometer. Outside this, lesser than this is the violet spectrums. Today you will come across lights which are polywave or multi-wave. They are the yellow plus the blue spectrum, okay? Now that light, basically anything outside the range of 400 to 500, which CPU does not absorb, will be a wastage. And I'll tell you why that is also important. So light which gives me possibly approximately 400 to 500 and which peaks at approximately 460 to 480 is considered a good light as long as I know I'm using the regular composite with CPQ as its photo initiator. Very few materials today, to the best of my knowledge, there are only 3 brands which are giving materials with the other photo initiators, that is bleach shades. But having said that, 99% of your restorative material will have your CPQ. Now, what happens is basically if you're having higher wavelength or shorter wavelength, sorry, multiple wavelengths, there are 2 things that happen. See, the blue light has the ability to penetrate much deeper as compared to the violet light. The blue light by itself will be a homogeneous light, but when you have more than one spectrum of light, there's basically the homogeneity is not maintained. So when there are 2 distinct LEDs, okay, they do not give additional benefits to your curing. In fact, what will happen is the blue and the violet light emitting diodes that are placed will give different wavelength of light. Now these will hit your photo initiators, of course, and the CPQs will absorb the 400 to 500, but the wavelength which is shorter, the 300 to 400, will not do anything to the CPQ, right? That means that portion of CPQ stays uninitiated, which means I'm not getting a good conversion of monomer to polymer. So unless you're very, very sure that your material has any other photoinitiator, do not go for a polywave. Try and stick to a monowave. Okay, that is between 400 to 500 nanometers. Another thing, of course, is the light intensity. How much intensity is required? If I asked you, is there a minimum intensity or maximum intensity? Not really. I've seen lights, people having light of 200 milliwatt per square centimeter intensity, using it for years together. And today in market, there are lights which are available at 2000 milliwatt. What do we select? Basically, light intensity also affects your exposure time. The amount of light that is received by the composite in 1 second over a square centimeter is the irradiance, right? And that the energy that is there, that is created, is measuring joules per centimeter. I'm sorry, I know this is a little theoretical. I'll come to the practical aspect of it. So typically when I'm curing my composite, for 1 square centimeter, I need a light which is going to generate 16 joules per square centimeter. Just remember this as your basic physics law. Okay. Now to generate this 16 joules per square centimeter, it all depends on my energy is constant, right? I require 16 joules. Now, what can change is the time, right? My intensity of the light will also stay the same. My time changes. So that is why when we ask people, how much time do you cure? And they give me a 10-second or 20-second or 50-second answer. I ask them on based on what are you deciding this different time? Why are you saying you cure your material for 10 seconds, whereas the next person is saying 50 seconds? Is there any logic behind it? Most often than not, there is no logic. Most people do follow what they've been taught in colleges. So let's understand the energy is constant, the intensity of our light will be constant. So what changes is our time. If you have intensity, typically you'll see lights between 500 to 1000 milliwatt per square centimeter. In this range, you require around 5 to 10 seconds to get 5 joules. That means around 15 to 30 seconds for your 16 joules. So let's say a light, most lights today are ranging between 500 and 1000, which would take around 15 to 30 seconds to cure. And a 15 to 30-second cure is good enough if the light intensity is in this range. Of course, if your light intensity is very high, theoretically it would take you a second, and if it's very low, it would take you days together, theoretically. But this really doesn't work that way. This law of reciprocity doesn't apply as far as light is concerned. I'll just give you a very quick example. If you're baking a cake, there's a very specific example for temperature for baking cake, right? I need to bake my cake somewhere between 350 and 425. I know that this range may the cake gets baked better, faster, through and through, right till the inside. No, the center of the cake doesn't stay moist. And I also know that at this temperature, it takes me a particular amount of time. So between this temperature, it would take me, let's say, 1 hour. At 100 degree, can I think, oh, let me keep it for 2 hours and reduce the temperature? Do you think you'll get exactly the same type of cake? Or let's say if you keep it at 900 degree and you say, oh, let me bake it in 2 minutes. Do you think you're going to get a good cake? So the same philosophy is maintained in light curing also. There is a specific safe zone from 800 to 1200 in which you get proper light where the curing is considered good. Just because your light intensity is more does not mean your efficiency of curing is more. And if your light intensity is less, does not mean you can keep curing it. People say I cure in 60 seconds because I want to be very sure of cure. It doesn't work that way. So please note an average of 800 to 1200 milliwatt is what is required. There's another twist to this, of course, I'll tell you. Uh, so basically, there is something called, okay, I did not realize this theoretically because these are all my workshop lectures in which it's very easy to show all these things. Theoretically, slightly again difficult to just read it out. But my tip, okay, as far as the tip is concerned, what is important is you take a wider tip as opposed to a smaller tip. For a, let's say a bigger cavity, if you have a smaller tip, you actually need to do it into two phases. You cannot move your light left and right. Your margins to be ensured that they come within the tip range. There's something called beam profile. What basically is beam profile? If you were to cut your light beam and if you saw the profile, now this is how your light will look. There will be areas where there's 100% intensity, there are areas which is lesser, and by the time you reach the rim, it will be least. So if my 100% was, let's say, 1000 milliwatt, over here I'm getting 1000 milliwatt, but over here, let's understand, I'm getting 20 milliwatt. So if my tip was small and if I didn't place it properly over it didn't cover the margin, let's understand, as you go towards the periphery, the intensity decreases over here. All right, so that is another important reason for having to needing a uniform beam profile. Now this is a good beam profile. There are various types of beam profile. Again, just quickly, I'll just show you some examples, can't explain more. So beam profile, let's say of this light is like this. There are two LED lights where the beam profile like this, but if you note at the center, it's showing this blue is around 10 to 20%. Even if I had a light of 1000 milliwatt, what I'm doing is at the center of the cavity, I'm only showing it 200 milliwatt, right? So different kind of this beam profiles are available. Of course, you need to, this would not be published data. You need to look it up in the product profile of that light, going probably online or checking the scientific data of that light. Beam collimation is another thing. Importantly, let's understand if this was my class 2 cavity or class 1. I'm holding this near my occlusal end, right? My first layer is going to come here, my bond. That means when I'm holding my tip here, my light has to travel this distance at the good intensity to be able to cure this aspect, right? Which means the beam of my light should be quite uniform and strong right up till the base of your cavity. Not all lights will give that. Some lights are very strong. So all these lights are starting with 1500 milliwatt intensity, but by the time they reach a particular distance, the intensity keeps decreasing. So sometimes the decrease can be so much that there is actually no light over here, and sometimes it might be enough. So different lights will have different beam collimation. A light which has good beam collimation is required. Why? Because my first layer of bond, if that is not curing properly, I don't think I've got a successful this. And then we talk about composites being giving sensitivity to the patients. Let's understand these small factors which affect. So having a good beam profile or the depth of the cure of the light should be good to reach even your 6 to 7 mm deep. This again would probably be a data which you will get in the scientific product profile. Obviously, the ergonomics are very important. We can't have something like this. Go for a light which ergonomically is, good for you, the patient compliance. As I mentioned, light ranges various. I mean, as I mentioned, 2000 to 2 lakhs, and it could be 400 to 5000 milliwatt. There are various pulse cure, ramp cure, this cure, that cure. Which of this should be decided? Something very simple. As I told you, there are 2-3 factors. I told you the first was the intensity. Second was the what photo initiator is being used. Based on the intensity, you'll define the timing, and the depth of the cure and the beam profile also are two factors which you need to look into. These are the hidden factors. If the beam collimation is not good at zero, even if I have 1500 milliwatt, by the time it reaches to the base of the cavity, I might not have 1500. If let's say there's 50% drop, I'll only have not more than 700 milliwatt. So these are some of the important aspects. One of the lights, of course, that I highlight on is the ELIPA Deep Cure light, 1470 milliwatt. So by the time it reaches the 6 mm depth, it has become 12, approximately it goes to 1250 milliwatt, which is good enough for my base level. Wavelength is 430 to 480, back coated this, which prevents any scatter of light. 120 minute of consecutive light curing. Now this I completely missed to tell you, battery charge. You will see that most of the lights, as the battery charge goes down, the intensity goes down. Not the right way to go about it. Irrespective of battery charge, your intensity should always be uniform. Otherwise, you'll have to always charge your battery to 100%. Even between two patients, you need to go back and charge your battery. Okay, so deep down, you need a better life. That is what matters. There is a conference that is held by for just light curing in Halifax every 4 years, mostly in Canada somewhere. Last time it was in Halifax, so it's called Halifax Consensus Statement. There's a lot of this do's and don'ts. Just big pointers. Always wear your light guard or the orange glass. The ideal thing is not starting the light and looking somewhere. Even if there's a slight wrist movement, which you might not realize, the light beam has fallen on the adjacent tooth or not at all on the tooth that you require. It is very essential for first few seconds to look where your beam is shining, and after that take the light closer to the respiration, rest it on the tooth once the surface is cured, and then probably look somewhere else. Another thing is, of course, calibrating your light regularly and checking. Most often than not, you'll get this, it's called a spectrometer or light calibrator or something. They're available, they're quite expensive, I think 10, 12,000 or something like that. Or 3M gives you this value-based service. It's called, this is a check mark unit, which is shows the intensity right up to 6 mm per drop also. But please do check your lights regularly. Always your light tip should be clean. The best way to do is, put a cling wrap over this so that it doesn't touch the tooth surface or the composite. See, if the composite is not set and if your light has touched the tooth, the unset composite comes on the light and that will change. Even if there's one minute spot of material left behind, it completely causes refraction of light and the whole purpose of getting a collimated beam goes away, right? As much as possible, use a barrier. These days you get the sleeves also. Always follow the correct mode. The reason I'm telling you this is I know people who are using 1500 milliwatt or rather the deep cure light and curing it for 30-40 seconds. Of course, you're frying the pulp. You have to cure at that intensity only for 10 seconds. Please always follow the manufacturer's guide about what they're saying, which shade of theirs, how many seconds. There's a reason why this is done. After a lot of studies, this number is arrived at. If a manufacturer is saying cure my material for 20 seconds, he means 20 seconds. Of course, do check what the intensity they're referring to, but please follow that. Okay. Always place your light as much as possible on the tooth, not on your this, especially in your class 4s or your class 3s or class 5s, of course. The high intensity light will always cause irritation or burning to your, the best thing to do is always just place a cotton roll and then cure so that your gingiva is safeguarded. Look straight at where the light is. I did mention that. Please do not look away for a few seconds. Of course, not directly, but with your orange glasses. Cover the tip, this with tip. And light should be in one direction. Please, that's where the ergonomic comes in picture. Light should always be perpendicular to your tooth and not in a, I think there should not be a angulation like this, which will cause a shadow zone. This is incorrect. If at all you feel the need to cure from both the sides, you can always use two lights. Or maybe your assistant can hold one and you can hold one. And as I told you, light intensity drops over the distance. This is very important to check. So light intensity at 0 is equally important at light intensity at 5 mm and 10 mm. So let's say 10 mm is too deep, but most of our bays or the flow, your bond and flow will be applied at 5 to 6 mm. your intensity of light should be good at that level. Okay. Okay, quickly to sum up this entire lecture in one single slide, biggest cause of post-op sensitivity would be over-etching. I think, of course, in detail, I did not cover up etching in this. Etching, if it is said it is 15 seconds, it is 15 seconds. 15 is not 20 seconds, 15 is not 10 seconds. Get a timer, look at it. From 15, when you move to 20, you are exponentially increasing the percentage exposure of the etchant to your tooth. These are not things that you do randomly. These are very specific time-bound things. Look at your etchant. What does it say? If it says it is 15 seconds, do it for 15. If it says 30 seconds, do it for 30. Please follow the right etching time. Post-etching contamination typically happen if after etching you're asking the patient to gargle, naturally there's going to be a biofilm that will be created on the tooth. Ideally, you should just rinse it with copious water flow and for a long time. It should not just be one jet of water and finish. For few seconds continuously, you should flow water through the three-way syringe, of course, which needs to be collected in the Havak suction. After that, the patient doesn't get to gargle or spit or anything. After the rinsing is over, how much are you drying the tooth? If it is over dried, of course, it's going to be causing sensitivity. So basically, don't over dry it with an air blast. Just blot dry it after the rinsing. Or as I mentioned, you could of course use a bond like a single bond, which gives you very little of this post-op sensitivity. It takes care of this over drying for you. Insufficient light curing of the bonding agent. Of course, we have seen this insufficient application of bond. Again, please go back to the manufacturer instruction. I think bottom line is for every material, every time you open a new box, read the manufacturer's instruction. They are the people who have worked for hours and days and months to get you the right temperature, time, usage, give you the optimal properties that are possible with that particular material. If I'm using a material who has told me to use it for 10 seconds and I say no, I'll use it for 20, I'm doing something which the manufacturer has already tested, which will not work best for that particular material. So please read the manufacturer instructions always. As I mentioned, insufficient bonding, agar do coat likha hai, to please apply 2 coats. If one is written, please apply only 1 coat. All right. The thickness, depending on how thick, I mean 2 mm thickness, if your material gets cured, very good. There are some material shades which do not get cured in 2 mm also. You need to put 1.5, especially for shades of A3, A5, sorry, A4, B3, etc. and insufficient curing. Lack of bonding can of course be because of your cavity preparation. Okay, etching not done properly, rinsed very much faster, contamination, that is your gargling the patient does, or if your composite is not the right. Okay, so that was a quick summation of what I have been speaking about. Let's look at, solution-based things. We need to find solutions and not just like single material, what it does. For details regarding any of these materials or information more on this, please try and connect with Satya or Deepesh. Sir knows them very well. These are highly trained 3M members in the materials availability, of course, and rest of your questions regarding the, how to use, etc. For any kind of scientific information, more along the procedural information, etc., please feel free to connect me at this email ID and this contact number. I will revert back to anything, especially students who require more data. We have a data overload. We have a huge e-library with so much information about materials. So anybody needs to do any more studies or interested in anything more, please do feel free to reach out to me and I can help them with data. With that, I finish my presentation. I'll just quickly go back to okay, Zoom, on which I switch on the video, right?
Yes, ma'am.
I'm not able to see where the video is. Give me a moment. Yes, I saw that. Okay.
Thank you, ma'am, for this wonderful lecture. You have covered a wide range of topic
Yes.
from material science to restoration. I'm sure that the participants will have proper knowledge right now to select what kind of material to be used for restoration, what kind of bonding agent should one use, or for the finishing, what is the proper choice of material. Thank you very much, ma'am. And now I'd like to request Dr. Rahul, who is a reader in the Department of Consultant Dentistry and Endodontics, Mansoor Dental College, to kindly take a question and answers session.
Thank you so much, sir. Thank you so much, ma'am, for wonderful session, ma'am.
Thank you.
Ma'am, a few questions are there.
Please.
Ma'am, first question is asked by Dr. Prashant. How can I avoid white lines on margins that appear after finishing procedure?
Okay. Very interesting, because yes, it's a very common issue. Just give me a moment, please. Yeah, thank you. So basically, if it's specifically a white line you're talking about, then the reason could be two. One, your material shrinkage is very high, which has pulled away from margin. This we'll see only in the anterior restoration, but in the posterior, you might not be able to appreciate this. But more commonly than not, it's to do with your finishing and polishing. If your finishing and polishing is not done from the restoration to the tooth aspect, that could give one. Two, again, depending on what kind of like if you're using a disc and the mandrel that is used, the mandrel might be touching. So there's a particular angulation at which you should be. So understanding the proper technique. If the angulation is not correct, the mandrel might be touching the composite surface, leaving white lines, etc. White lines may, but spots can be seen if when you're adapting the restorative material on the tooth. Ideally, you're supposed to place the material and press it ahead. You're not supposed to place it and, you're not supposed to do this. The material sticks to this, comes up. Again, you're trying to stick it, some part of it again sticks and comes. So you create voids in the material. So that also could lead to all these discoloration, black spot, white spot, etc. But the white line per se, as I mentioned in interiors, if your finishing polishing is correct and if you've chosen right material, you will not get one. Second part is, if you're not referring just to a white line, but that gray line or the demarcation line, I think I quite elaborately told you, it had a lot to do with your bevel making and finishing and polishing of your bevel.
Yes.
I hope.
Thank you so much, ma'am. Ma'am, yes, ma'am.
Okay.
Ma'am, second question by Dr. Rakshana Siddiqui. What technique can be used to repair composite restoration?
Dr. Akshal, see, I think depending on, again, I'm just giving you a very, very practical view. If the composite was done by me, I might repair it. If the composite was not done by me, I will redo the composite, because I do not know the bond that is used, if there are marginal leakages, etc., etc. So to be on the safer side, once I know if that is the case I've done, and I know I've done it the right way, then I know, okay, fine, there's a fracture, let me solve it. So the way to do it, first and foremost, why is there a fracture? Is there an occlusal interference? Is there any eccentric bite position which the patient is going in, which you have not realized during checking the high point, etc.? So first, eliminate the cause of that, because otherwise composite should not break. Okay, firstly. Secondly, if at all for some reason it has broken, some repair needs to be done. Very simple. You can either take the single bond universal that I was talking about, which has your MDP, it has a primer, etc. Everything. You could scrub that, okay, dry it, apply your material, and then cure it. That's one thing to do. Or else, if you have the availability of the fourth generation, what we had, the adhesives and the primer separately, you could actually go through your etching, priming, this, that. But all this is only if that surface is completely clean. Ideally, there should not be any biofilm on that. There should be proper isolation. So composite repair, I would not suggest unless it's for emergency, patient को कहीं जाना है, टूटा हुआ, etc. But long run के लिए avoid composite repairs. And if you want to do it, as I mentioned, you could actually go through the steps of etching and bonding.
Thank you, ma'am. Ma'am, next question is by Dr. Nishu Singh. Should a base of floral composite be placed prior to the placement of restorative composite material? I think we already answered this question.
I've answered, I think that was before probably.
Yes, ma'am. Yes, ma'am.
So yes, Dr. Nishu, that definitely needs to be done. I, for one, have never never restored my posteriors without a liner. Never. Okay, that's just how strongly I believe in that. Okay. Yeah, I hope
Okay,
that
ma'am. Next question is asked by Dr. Pawar. How do we assure a good color stability in composite restoration?
Okay, so in composite restoration, there are two aspects to having the good color. One, your material itself should have very high level of aesthetics. I told you the nano hybrids and the nano materials today are ones that give you very high aesthetics. One. Two, it's also depending on how much you finish and polish. Okay, unless you go through each and every step of finishing and polishing, you will not get that absolute perfect. I have seen cases which are 10 years old where there is not a single mark, and there are cases which are 2 months old which has a layer of discoloration. This of course could be, of course, starting right from my composite material. If it's like no, if it's either the hybrid or the micro hybrid type, that could attract plaque, etc., because of the irregular surface. Also, if my curing is not done properly, that could be the reason. Proper uncured resin. Third could be, as I mentioned, finishing, polishing. हमको बहुत घाई होती है. By the time we finish the restoration, we're so tired that we just want to do something and send the patient away. Most often than not, it happens. So please factor in the time that is required for finishing and polishing. Again and again, I keep saying restoration is the simplest thing. It takes 5-10 minutes. एक layer, दूसरा layer, तीसरा layer, finish. उसमें करना क्या है? Finishing and polishing is what really should take maximum of your time. So all these three would contribute to no discoloration happening. Again, I told you materials with good polish and polish retention. That is your nanofil materials. That should help you. Even the microfilms have good polish retention, but no strength.
Thank you so much, ma'am. Ma'am, my last question by Dr. Bennett Babu. Composite restoration just after bleaching is contraindicated, but combining them has always brought additional benefit. What is your take on this, ma'am?
Then I would like to ask a counter question. What do you mean by additional benefit? What is the additional benefit you're getting to maintain the color uniformity is what you're saying?
I think so, ma'am.
All right. So of course,
Yes,
I again do not think composite should be done before bleaching. It should be done after bleaching for various reasons. One, of course, I do not know exactly how this patient cut teeth are going to react to this percentage of my bleaching agent, right? You see variations. It doesn't happen that in everybody the bleaching will happen to that particular level. It all depends on the prismatic or prismatic, etc., etc. So first, bleach, okay, and then put your composites. I'm not in favor of bleaching the composites also. Once I finish and polish my composites, I don't want to touch it because that's the level of polish that I reach to. So finish your bleaching first. Of course, then you have to also look at the post bleaching sensitivity, etc., etc. So many issues. Why do you want to put all of those together? My personal view. I really do not know technically if it can be done or if it's viable. I'm sorry, I don't know that.
Thank you so much, ma'am. Thank you so much for a wonderful session, ma'am, and such a knowledgeable talk. I hand over to Dean sir to say thanks.
Just a moment.
Ma'am, I think so. We have cleared all the doubts of the participants.
Okay, great.
If any participant or anybody would like to revisit this webinar, one can go down to Mansoor Global University YouTube channel to watch over there.
Okay.
I would like to extend my special thanks to Mr. Dipesh and Mr. Iyer for bringing this webinar on our platform. I would also like to thank everyone for joining us today, and I wish, ma'am, to see you in Bhopal at Mansoor Dental College, and for a workshop to be done over here. That would be our pleasure to have you with us.
Definitely. Thank you so much for inviting me, and definitely I'll try once all this is over.
Yes, ma'am.
Because there's no substitute to showing one-to-one and doing demo and hands-on. I know the challenges that one faces while understanding things online. Having said that, at least this is a good way of connecting, if nothing else. And thank you very much, Rahul. Thank you so much for helping me.
Thank you so much, ma'am.
Definitely. And thank you everyone for your kind, patient listening. Dipesh, Satya, thank you so much for arranging this. I'll take your leave. Stay safe. Bye.
Yeah. Bye. Bye. As of now. Thank you.